Hi there. Part 2 of antenatal screening, and this video is about fetal aneuploidy with a focus on trisomy 21 and 18. As we saw in the first video, we discussed the maternal screening. That's represented here by 1, 4 and 5. Today's focus will be on the antenatal screening, looking at chromosomal abnormalities of the fetus. What screening tests do we have available, and what diagnostic tests? Screening tests, there are 3. First trimester screening combined, second trimester screening, thirdly the non-invasive prenatal testing, NIPT. That's, by the way, not yet part of the free public hospital screening system, and at this stage women have to pay that out of their own pocket. Diagnostic tests, we have 2, the Chorion Villus sampling, CVS, and the amniocentesis, or the amnio or AC. Let's commence with the screening tests. The combined first trimester screening consists of checking maternal blood for 2 analytes. Firstly is the free beta hCG, the pregnancy hormone produced by the syncytial trophoblast, and secondly PAPP-A, a protein specific produced by the placenta, PAPP-A. We should take bloods between 9 and 13 weeks. These analytes are combined with an ultrasound scan between 11 and 13 plus 6 weeks, where we measure the neck fold of the fetus or the nuchal translucency. In South Australia, the so-called SAMSAS, the South Australia Maternal Serum Antenatal Screening, they calculate an individual risk for the woman involved, and they include, among others, the maternal age, smoking or not, IVF or not, diabetes or not, etc. So the woman receives, after the test, an individual risk calculation for her baby to have trisomy 21 or 18. The current, for this test, the detection rate, the sensitivity for trisomy 21 is about 90%, with a false positive rate of 5%. That's not bad, but not yet perfect. That means that 5% of the women will be offered a diagnostic test, so either a CVS or an amnio, which eventually will show a normal fetal karyotype. So a test which we could have avoided in the first place. The risk could we have avoided, and the stress and anxiety. If we go back to the nuchal translucency, we see here a cross-section through the developing fetal lymph system, depicted in green, and the nuchal translucency, as we see here on an ultrasound scan, between the 2 markers, the NT, that is precisely the space we are measuring. On the left-hand side we see a normal nuchal translucency, and the right-hand side we see increased nuchal translucency. By the way, on the left-hand side the picture shows as well the nasal bone, which is quite reassuring. And we know if the nasal bone is absent, that would contribute to the risk of trisomy 21 as well. Okay, this is the nuchal translucency. It has to be done in a specific way. It requires special training by the sonographers or radiologists. Here we see an example. I will give you a few examples of SAMSAS reports, just to give you an idea how to read the report. Because we see here a report of a 30-year-old lady, and she has the top part here we see the background risk, and that's the so-called pre-test likelihood, and that risk is based mainly on her age. Then we see depicted the nuchal translucency here, that is 0.97 multiples of the median for that gestational age, and the serum analyze results are here. It's good to look at these results rather than just looking at the post-test likelihood, which shows here for this lady that she is not at increased risk for trisomy 21 and 18. How would you manage this case? I think firstly, explain this to the lady. She's not at increased risk, but be careful. That does not give a guarantee, no warranty, that the baby is not having either of two trisomies. So the risk is low but not zero, in other words. Another combined first trimester screen test now of a 32-year-old. We already see that the pre-test likelihood is increased because of their age, and the total result you see now because of the post-test result shows there's an increased risk for Down syndrome, 1 in 2, and trisomy 18, 1 in 30. And why is that so? This lady has a high beta hCG, slightly higher than the multiple of the medium, and a lower than average PAPP-A, and interesting that the nuchal translucency is well above the cutoff level of roughly 3.5 millimeters. So we can now see the result of the test. What advice would you give this lady? I think you should explain that there's an increased risk. That is not a diagnostic test, so we offer her a diagnostic test. This lady is now already 13 weeks. When we have the results, she's about 14 weeks. So in practice, daily practice, we would offer her a diagnostic amniocentesis. Anything else you need to consider? Yes, this is maybe a bit high level, but an increased nuchal translucency points at cardiac malformations. It could already point at early cardiac failure because there was a backup of the lymph through the vascular system. So this lady should be offered also a detailed fetal cardiac echo. But anyway, this is a little bit higher level. Sorry that I got a little bit carried away. Another lady, now this lady is 41 years of age, and we can already see here that her risk before the test was increased for both T21 and T18. Now after the test, because she has a very good test result, the risk for Down syndrome came down to 1 in 601, and the risk for trisomy 18 was increased 1 in 2. So again, I think it's fair enough to say we offer her a diagnostic test. And of course, it's the choice of the mother, the parents, whether she wants a diagnostic test and the risk involved with the test, or she has the right to decline. Some women would say, look, I accept this risk, that's fine, and others would like to proceed with a diagnostic test, that's fine too. Another very interesting example is here of a twin pregnancy in a 28-year-old. A dichorionic, diamniotic twin pregnancy, so we have two separate placentae and we have two separate amniotic sacs. The top panel shows the result of the first fetus. By the way, the serum analytes, of course, are shared, so they will not be able to discriminate between fetus 1 and fetus 2. But here we see the NT of the first fetus is 1.8, it's well below the threshold, and fetus 2 has a slightly increased NT, slightly bigger, but still normal, 1.9. So both fetuses are not at increased risk for Down syndrome or trisomy 18. So this shows that in this example, in a twin pregnancy, we can calculate the individual risk of each fetus. Good. Conclusion, the combined first trimester screening, we offer this as a diagnostic test, and if we find an increased risk for either one of two or both, then we first explore what the woman would want, what the couple would want. You have to explore what they would like to do if one of these diagnoses is confirmed, whether they would consider genetic termination or they would accept, and then you proceed. So very delicate discussions. It's also good that you look at the individual serum analytes, as we showed, rather than at the end result. Offer a detailed cardiac echo if the nuchal translucency is more than 3.5 millimeters, and the echo is usually done at 18 to 19 weeks. Interesting as well, if the PAPP-A is a little sidestep, but if the PAPP-A will be less than 0.37 multiples of the median, which is less than the 5th percentile, we would offer an uterine artery Doppler to be added to the usual morphology scan. If that uterine artery Doppler would show bilateral uterine artery notching, that means the baby would be at risk for growth restriction. I will discuss that in one of the other videos. But that means this screening test does more than point at the risk for trisomy 21 and or 18. Second screening test is the second trimester screening. If a woman's gestational age is more than 14 plus 0 or less than 21 weeks, we can offer her a second trimester Serum screening test. It's paramount that we know exactly what the gestational age is, and I refer to that, to a video where I explain this into detail. Now we don't use an ultrasound scan, but just we use 3 serum analytes: the alpha-fetoprotein, the hCG, pregnancy hormone, and the unconjugated estriol, E3, female hormone. SAMSAS actually will give us a risk calculation not only for trisomy 21 and 18, but also for a neural tube defect. So this is not the primary aim of my test, but it has this information, makes this information available as well. Yeah, this is the accurate dating video, essential for everybody working in ONG, that you know, that you master this. It's not higher maths, but it's a little bit of math. Alpha-fetoprotein, a slide which shows on the left-hand side the alpha-fetoprotein levels. When you compare Down syndrome, the alpha-fetoprotein median appears to be a little bit shifted to the left. The unaffected Gaussian distribution is in the middle, and to the right we see when there is a spina bifida. What is important to note that the alpha-fetoprotein is produced in the fetal liver in a high concentration, and as there is some leakage through the fetal skin, as is the case in the spina bifida, we find this in a high level in the amniotic fluid and also in the maternal serum. So alpha-fetoprotein increased. What would be the next diagnostic step? We offer a detailed ultrasound scan, with special attention to neural tube defects. Second trimester screening example here. This lady of 20 years of age has not an increased risk of Down syndrome or trisomy 18. However, the risk for an open neural tube defect is roughly 1 in 30. So, detailed ultrasound scan focusing at the brain, the ventricles, and the fetal spine. The third diagnostic test. That test became available in the last couple of years and is a fascinating development. The Americans are here leading the way. Already in December 2012, the American College of Obstetricians and Gynecology recommends the NIPT test, the non-invasive prenatal testing. Here we see, fascinating, that already from 10 weeks onwards, the green dots is fetal DNA that crosses the placenta, so microparticles of DNA cross the placenta and enter maternal circulation. So we can already find fetal DNA particles in the maternal circulation from 10 weeks onwards. And a very clever laboratory technique. They take a bit of blood from the mother and they are able to gobble these DNA particles together. A lovely, maybe typical American name is the shotgun massively parallel sequencing, MPS. That's one of the techniques used in the laboratory. After 10 weeks we take a blood sample of the mother. The result is usually available in about a week. Depends, of course. Nowadays the laboratories are available in Australia as well. In the past we had to ship it to California, so there was a little bit of a delay because of the transport of the blood sample across the Pacific. This is important. This is a superior screening test. It has a low false positive rate, not of the 5% of the tests we have in South Australia, the combined screening test, but only 0.2%. So far fewer women have to be offered a CVF or amniocentesis to confirm the increased risk. And of course, the associated risk of miscarriage. And we will discuss that later on in this video. We have to be careful. The AJOC, American College, got really carried away because we have not seen the research data as a screening tool in the general population, which is at low risk for aneuploidy. In South Australia, it's not yet reimbursed by Medicare or the South Australian government, and the out-of-pocket spend for women is about 400 to 500 Australian dollars. We expect that this price will come down as more laboratories will master this special technique. Here I have an overview of the various companies who offer these tests, and you see this is the test. Here are the first, the second, the third and the fourth company. Here is the sensitivity to detect trisomy 21. It's actually close to 99 and 100%. Sensitivity for trisomy 18, also very reliable. And here the lower figure is the false positive rate, so extremely low. It's a fantastic test. We see we can also test for trisomy 13, Fetal syndrome. We can screen for Turner syndrome, and of course they will tell us as well with a very high predictive value whether the baby is a boy or a girl. So what does this mean? The NIPT price will come down. More research is required in large populations at low risk, and eventually this will replace the current first trimester or the second trimester screening test, I'm convinced. Interesting that it will free up the capacity in our ultrasound departments who are really struggling and sometimes inundated. They're a little bit too popular. Another consequence will be that we will request fewer diagnostic tests, CVS, and hardly any amniocentesis. Next part of the video we focus on the two diagnostic tests which we have already mentioned. The CVS, the Chorion Villus sampling between 10 and 14 weeks, and the amniocentesis after 14 weeks. Of notice, and that's quite confusing, some people have the impression that the NIPT test is a diagnostic test. No, it's a screening test, but a very reliable one. The CVS, done between 10 and 14 weeks. Advantage is that the result is usually available well before the 14 weeks, and if the trisomy is confirmed and the parents, the mother, decides to terminate the pregnancy, we can perform a surgical procedure which is a suction, dilatation and curettage. By the way, the CVS in itself has a slightly higher risk of miscarriage, between the 0.5 and 1%, higher compared to the amniocentesis. In South Australia, we refer women to the Women's and Children's Hospital for the procedure. So it's centralized because we are relatively, population-wise, a small state. The amniocentesis, a great diagram which shows the amniotic sac filled with amniotic fluid, and that is what we're aiming for. Take some 2 × 10 mils of the amnio fluid away and send that off. This procedure is done under ultrasound guidance, and for the doctor performing this procedure, you know exactly where the tip of the needle is. It's fairly straightforward, but for the woman involved, it's quite scary because she will focus on the fairly long needle. Usually we perform this procedure after 14 weeks because before that there's not enough of amniotic fluid to take 2 × 10 milliliters away. If the lady is obese, we usually prefer to do it a week later because it's slightly more challenging. Procedure takes 15 minutes, can be done under local anesthetic or no anesthetic because it gives only a little pain whether you give local anesthetic or insert the needle straight away. However, the vast majority of women are scared. It's in a dark room, in an ultrasound room, and they fear the worst. Risk of miscarriage is roughly 0.5%. It's probably even less at the moment. Another risk is very rare, that it can result in leakage of amniotic fluid or infection. Be aware that after CVS and amnio, we should administer NTD prophylaxis if the woman is rhesus negative. What can we do with the CVS material or the amniotic fluid? We send it off to the laboratory for so-called FISH test, which is partly telling us the chromosomal pattern, or to a complete karyotyping. What does this FISH test mean? It has nothing to do with fishing, but it's a mnemonic for fluorescent in situ hybridization, another very clever laboratory technique. The result is known within 1 or 2 days. It's a preliminary result. In South Australia, we offer a so-called 5-probe FISH test, which checks for the chromosome 13, 18, 21 and the X and Y chromosome. A co-payment is required of about $216 Australian dollars, and we have the agreement, of course, as soon as the result is known, we'll inform the pregnant lady. In contrast is the complete karyotyping. That's an official culture technique where the chromosomes are rested in the metaphases, as you might remember from early years in medical school. It takes about 12 to 14 days. All 14 chromosomes will be analyzed, and that will give a final result. Here's a little diagram of the fluorescent in situ hybridization technique. It means basically they flag the 5 chromosomes of interest, and you see them under the microscope. And here we see a picture, the actual picture where chromosome 21 is present 3 times, so confirming the suspicion of the trisomia 21. And here on the right hand side we see the good old full karyotype where this is chromosome 21, is present 3 times. If the higher risk is confirmed by either the FISH or the full karyotyping, we enter a quite challenging situation with the couple. They have in principle 2 options. They could accept the diagnosis, or they could decide to terminate the pregnancy. There's a little typo here. Sorry. If they would accept the continuation of the pregnancy, the morphology scan should pay extra attention to the heart, looking for congenital malformations such as a VSD and ventricular septum defect. Difficult decision because trisomia 21 children, there's a huge range. There are now Down syndrome babies going to high school, and most children are happy, and of course there is a developmental delay. If the woman, the couple, would opt for termination of pregnancy, we usually, this is after 15 weeks of pregnancy, and we usually offer an induction of labor. That means she will be given mifepristone, which is a progesterone receptor antagonist, usually followed 48 hours later by misoprostol, which is a prostaglandin E1 analog. That results in a mini labor process: contractions, pain, delivery of the baby, delivery of the placenta. Quite often that's more challenging because there's a higher risk for an incomplete placenta which needs to be removed. It needs to be removed in theater. This process, this delivery, can take up to 2 days. It's emotionally hard, and of course for us as doctors we cannot change the outcome. We only can support the couple and the family members in the process of frustration, emotions, and eventually coming to acceptance. A very special experience as an obstetrician. You can't fix the problem, but you can offer just your human support, which can be very meaningful as well, I can tell you. So very interesting. Don't force women to do a quick decision. Allow them to think about it. It's better they think about it for a few days until they come to a balanced conclusion rather than a quick decision to terminate the pregnancy. By the way, whether you opt for a surgical evacuation or this induction of labor, both have pluses and minuses, also psychologically. So it's a very personal choice as well. What about trisomy 18 or Edward syndrome? Edward described this syndrome in the 1960s. These children have a severe intellectual, developmental and physical disability. So that's completely different to the trisomy 21 children. 90% of cases will result in an intrauterine fetal death. 5% don't even survive the first week and 5% do not survive the first year. So the outcome is very bleak. That means that the decision what to do appears to be somewhat less challenging for most parents. But avoid a knee-jerk decision. It's okay to give them time to think what to do, what's the best for them. Some women opt to wait and allow Mother Nature to make the decision. Some women might feel if they decide not to continue with the pregnancy, that will result in feelings of guilt for years to come. Emotions, despair, sadness are no less compared to the fetus diagnosed with trisomy 21. And here again, genuine support, empathy is non-negotiable. That's always part of what we offer. I have now a few pictures. It could be slightly confrontational. On the left hand side we see a diagram with the typical appearance of the characteristics of an Edwards syndrome baby. On the right hand side a stillborn baby, which shows this in a real situation. Yeah, this is unfortunately part of obstetrics as well. It's not always normal vaginal deliveries and perfect babies. This is the other side of the profession, which is more challenging but can be quite satisfying as well, for the reasons I just discussed. At our hospital, the Lyell McEwen, this is the informed consent form for an amniocentesis, where we explain the procedure, the risk, the pros and the cons, and it's important for the junior doctors, if they complete this form, that they make sure the form is already in the file. So at the time of the amniocentesis, that the doctor who is doing this procedure is pleasant, happy that this is already completed. Another useful form in Australia is the pamphlet produced by the Royal Australian-New Zealand College of Obstetricians and Gynecology, Royal Australian and New Zealand College, and this is a useful pamphlet which explains the pros and cons of the Chorion Villus sampling and the amniocentesis. Useful to add written information to what you explain verbally. Okay, no surprise here. Here is the handout record where we document, where we supposed to document any issues. You could write down increased T21 risk, amnio, and a normal karyotype. So everybody will know that this is the case, and what the procedure was and the outcome. So just a quick annotation makes a big difference for your successor. So identify the issues with trisomy 21 and 18, manage them, refer for an amnio or CVS, and document the issues crystal clear in the appropriate box. Conclusion. For screening tests we have available 3 tests at the moment: the first trimester combined screening, 2 serum analytes, nuchal translucency if the woman is less than 14 weeks pregnant. Thereafter we can offer serum screening, second trimester serum screening, only 3 analytes, which offers as well a risk for neurotube defect, and the most modern procedure test is the NIPT test. High sensitivity and low false positive rate, and that's great, a great step in the right direction. It's a diagnostic test. That's a misunderstanding. People think it's a diagnostic test, it's a screening test. In South Australia at own expense. Diagnostic test, the FISH test, where we find out 5 chromosomes. The result is available in 48 to 24 to 48 hours. The CVS and the amniocentesis, where we can actually do the full karyotyping or the FISH test. This slide is a little bit misleading. We have 2 diagnostic tests basically, and we can offer then either FISH or full karyotyping. Never forget the human dimension. Whilst this might be at a certain stage in your career routine, for the people involved it's always emotional and it has a considerable psychological impact. Don't assume anything, make it explicit and listen. Sensible face-to-face counseling is essential. You have to practice and get used to how to break bad news with empathy. Allow the woman and the partner to, and the family time to consider the options. Okay, this concludes the second part of this antenatal screening trilogy, antenatal screening for fetal aneuploidy trisomy 21 and 18. The next video will be about major fetal malformations, as we sometimes find when we do an ultrasound scan, fetal morphology or anatomy scan between 18 and 20 weeks. Thank you for your attention, and if you want to know how Jimmy is doing, you have to look at part 3.